I'm going to be talking about alcohol use disorder. The interns actually got this lecture already as part of their social EM day during intern orientation. Well, it's like 4 months ago now. It's crazy. All right. So moving on, I'm going to talk about the outline of my presentation. It's going to be a quick one, but we're going to talk about the epidemiology of alcohol use disorder, the new GRACE 4 guidelines that came out in May, Kings County patients, and then we're going to talk about future directions and what we can do. Okay. So starting, this is a graph showing the CDC. The last time they analyzed data and took data in America was in 2022. They last reported on national drinking habits and found that approximately 17% of Americans reported binge drinking in the last week. Binge drinking was defined as drinking 5 or more alcoholic drinks in a given setting for men, and then 4 or more for women. That same year, they also reported that 7% of Americans also reported heavy drinking, which is defined as more than 15 drinks a week for men, and then more than 8 for women. As you can see on the graph, overall, the average percent of heavy drinking or binge drinking is, the graph is very similar, but it's over 12% kind of throughout America, with the middle part of America being a little bit blue compared to everyone else. The last time CDC also reported on alcohol attributable deaths was in 2020, 2021. At that time, it was reported that alcohol attributable deaths reached 178,000 nationwide, and approximately 4 million life years were lost in that year. Of those 178,000, 6,000 were acute deaths, which included alcohol poisoning, motor vehicle accidents, and suicide. And of the chronic causes of alcohol attributable deaths was alcoholic liver disease, which included cirrhosis and liver malignancy. Moving on to the GRACE guidelines. So in GRACE's own words, these guidelines are designed with de-implementation as a guiding principle to reasonably reduce wasteful testing, provide explicit criteria to reduce foreseeable risk, and define sensible and prudent medical care. This is the 4th iteration of GRACE. They've come up with other guidelines to kind of guide and recommend for things like dizziness in the ED. There's one that's coming up for chest pain, and kind of other run-of-the-mill bread and butter EM cases. The specific objective of the GRACE 4 guideline was to provide an evidence-based, patient-centric approach for clinicians in their evaluation and management of 3 conditions related to non-opioid related substance use disorders commonly encountered in the adult ED. I'm going to focus on the alcohol use disorder guidelines, but they do have guidelines on alcohol withdrawal and the use of phenobarb for alcohol withdrawal acutely in the ED, as well as cannabinoid hyperemesis, but that would be part of another lecture. Looking at the data that they use for the guidelines, this is the biggest trial that they kind of mentioned and cited throughout their guidelines, which is the combined trial. It's a trial that came out that was done from 2001 to 2004. They looked at 1,400 volunteers of alcohol use disorder patients that basically were looking to become abstinent from alcohol drinking. Their interventions were 16-week of either naltrexone, acamprosate, with the combination or without the combination of behavioral interventions, which included motivational speaking, group therapy, as well as kind of including outside peers and support systems. They also looked at the combination of acamprosate and naltrexone, and then they had a placebo group that had just placebo pills, no behavioral intervention. The primary outcomes that they looked at were days abstinent and reduction of heavy drinking days. They also looked at days until another heavy drinking day. The only statistical significant group in this study was the naltrexone and combined behavioral intervention group, which showed a statistical difference in reduction of days abstinent. However, all the other groups combined behavioral interventions with medications didn't see a statistical difference in days abstinent or days of heavy drinking, but it did show a harm reduction compared to placebo groups and placebo without behavioral intervention. Some other secondary outcomes that was studied in this was kind of the safety of medications. There had been a lot of other studies that showed that naltrexone and acamprosate together were very kind of cause a lot of side effects of like nausea, vomiting, decreased appetite, and abdominal upset. But they showed that both naltrexone and acamprosate individually cause the same symptoms, but at a decreased rate, around 12% compared to 20% in the combination group. All groups in this study did have a good adherence of about 85%, which about 12% of those patients required a dose reduction due to side effects. Moving into the recommendations. So the first one for alcohol use disorder is in adult ED patients of the over the age of 18 with alcohol use disorder who are not taking opioids, we suggest naltrexone compared to no prescription for the management of alcohol use disorder to prevent return to heavy drinking and or reduce heavy drinking. Additional recommendation 4, low certainty of evidence. Naltrexone is an opioid receptor antagonist. The mechanism of alcohol use disorder is inhibiting the opioid receptors involved in the reward pathway from being activated by endogenous opioids. It kind of helps with craving, but also just the actual reward pathway to decrease the pleasure pathway involved with alcohol use. The next recommendation was in adult ED patients over the age of 18 with alcohol use disorder. With contraindication to naltrexone, we suggest acamprosate compared to no prescription for the management of alcohol use disorder to prevent return to heavy drinking and or to reduce heavy drinking. Conditional recommendation 4, low certainty of evidence. The mechanism of acamprosate is an NMDA receptor antagonist and a positive modulator of GABA receptors. It's thought to be a glutamate stabilizer, resulting in the decreased positive reinforcement of alcohol and decreased withdrawal symptoms and cravings. By alleviating, they believe that the mechanism for alcohol use disorder is that it alleviates both the physical and psychological effects of alcohol cessation. This is the last part of the recommendations to see in adult ED patients over the age of 18 with alcohol use disorder. We suggest gabapentin compared to no prescription for the management of alcohol use disorder to reduce heavy drinking days and improve alcohol withdrawal symptoms. This was a conditional recommendation 4, but compared to the other 2 recommendations, had a very low certainty of evidence. This is kind of like the best part of the GRACE guidelines. It's they kind of call it like a clinician's pocketbook algorithm that you can use in patients that you would want to have kind of screened for and then are interested in pharmacokinetics or pharmacological help. It starts with confirm that the patient has alcohol use disorder and is interested in pharmacotherapy. We don't have to go through this right now, but it's something that if you're interested and you have a patient in front of you, something you could reference really quickly to make sure that you're offering the right medication for the right patient. This is a kind of second part to this, which if the patient has high reported withdrawal symptoms when they stop or reduce the alcohol intake, the recommendation for gabapentin. The reason it was very low evidence was because there's not a lot of studies and they didn't really cite too many. They cited one study that just looked at, it wasn't really evidence-based, it was just kind of provider and a toxicologist and also more so addiction health that suggested gabapentin as a form of alleviating some of these stressors and psychological effects from alcohol cessation. The one thing that GRACE 4 doesn't really cover is how you screen patients who have alcohol use disorder. So this is an audit C, which in 2004, the U.S. Preventative Service Task Force recommended screening for alcohol use disorder with the audit, which is basically alcohol use disorder questionnaire. It was a 10 questions that they used to determine if a patient fit under the umbrella of alcohol use disorder. This is a condensed version, which is just 3 questions. And recently, they also came out with a single question screening tool, which is this. So for men, how many times in the past year have you had 5 or more drinks in a day? And then for women is how many times in the past year have you had 4 or more drinks in a day? Now, the sensitivities and specificity of these tests aren't the best. They're about 60% for both. So you're going to catch a lot of patients that will screen positive for one of these questions, but might not necessarily be interested in alcohol use disorder, might not necessarily have an alcohol use disorder event. I'm sure someone like after a birthday or something like that would screen positive for such a question, but it might not be someone who would benefit from type craving. So looking at Kings County, it's after the Grace 4 guidelines came out, we looked at some of the data for Kings County ED encounters, and we found that the total ED adult encounters for alcohol use disorder were 1,417, with the total number of patients being 953. Of those patients, only about 6% were prescribed any anti-craving medications in the form of naltrexone, acamprosate, and gabapentin was prescribed, but in the setting of more chronic pain. 6% is about kind of the baseline that Grace also saw in patients kind of nationwide before there was these guidelines. So we're kind of at the expected prescribing rate for the nation. This is an example of our slicer dicer, showing kind of the prescriptions that we've been giving out. Naltrexone, acamprosate, and gabapentin. Most of these prescriptions, if you actually, I went in and looked at the chart, were mostly done by the catch team and kind of our addiction services as an outpatient. So looking to the future, the GRACE guidelines are, I think, a good stepping point in the future as kind of giving us what I feel is good recommendations, but also kind of empowering for us as EM physicians to treat this specific population in a different way that maybe we're doing now, given our prescription rates being only around 6%. A lot of times we might not know about these medications. We might not feel comfortable because we don't prescribe them frequently. But I feel like even though there's not a lot of evidence and not a lot of studies that are going into the care for these patients, having the GRACE guidelines as a guideline that we can use to facilitate care for these patients and establishing care is, I think, something that we can look forward to. Since the GRACE guidelines have come out, I've prescribed naltrexone and acamprosate to at least 6 patients, which before the GRACE guidelines I hadn't done. Looking at some pillars and some things, kind of using the opioid use disorder pathway that we already have in place, and speaking with the addiction team and Dr. Mark, some pillars that we would like to go forward with is placing the catch console. That's the first thing that Dr. Mark said. Basically, it basically puts into our system that these patients have been to the ED and have wanted either addiction services, and it allows them to track basically their use of our ED system and our hospital system to see if maybe it's someone that can reach out to and loop into addiction services as an outpatient. So they say no matter what time of the day, whether it's in the morning, night, and they're not going to come around, still place the catch console because they will follow up in the morning. Or if it's a weekend call and they don't necessarily have anyone to come see patients, they will follow it up on Monday. The other pillar is offer and prescribe anti-craving medications. Obviously, there's it might be a little bit more of a discussion. You can use the single question for alcohol use disorder. Last time in the past year, how many times have you had 5 or more drinks for men, or 4 or more drinks for women? But again, it's more of a discussion and kind of a conversation that you might have at the end for a patient that you are concerned or think that would benefit from anti-craving medications. And finally, the last pillar, similar to the opioid use disorder, is place an ambulatory referral for chemical dependency and addiction clinic at the time of discharge. These are my references.